All right, everyone, this is Tim Farber again. I'm sorry. So Dr. Such is still having some connectivity issues for the sake of everyone's time. I figure we can just get us started, and once he hops on, he can take over the MC duties. I just wanted to welcome everyone to the first in a series of webinars with Medical Society of Virginia and VDH regarding COVID-19 testing. MSV is extremely happy to partner with the Virginia Department of Health to provide continued updates on COVID-19 testing and the current status of the virus in Virginia. Today, as I mentioned, is going to be the first in a series of webinars by VDH and MSV to keep the physician community of Virginia up to date on the current events of the COVID-19 pandemic. Today's webinar is going to be broken into two portions. The first is going to be a presentation by Dr. Brooke Rossheim, Health Director of the Rappahannock Area Health District, and Dr. Melissa Briggs-Hagen of the Centers for Disease Control and Prevention. Following their presentation, we're going to be hosting a Q&A session about the COVID-19 testing in Virginia with a panel consisting of the previously mentioned speakers, as well as Dr. Denise Toney, Director of the Division of Consolidated Laboratory Services, and Dr. Diane Woolard, Epidemiologist and former Director of the VDH Division of Surveillance and Investigation for the Office of Epidemiology. Before we start, I'd just like to remind everyone that MSV and its staff have continued to work diligently to pull any and all relevant resources related to COVID-19 on our website at msv.org/COVID-19. We will post a recording of this call on that webpage later today, should any of your colleagues like to listen who could not make it this morning. As this is a CME accredited webinar, I must issue you the following statements. No commercial support was received for this activity. There are no reported conflicts of interest for any individual in a position to control the content of this program or speakers presenting in the program. In support of improving patient care, this activity has been planned and implemented by the Medical Society of Virginia and VCU Health. VCU Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. VCU Health designates this lab activity for a maximum of 1 AMA PRE Category 1 credit. Physicians should claim only the credit commensurate with the extent of participation in the activity. All right, so with that being said, we have a large number of people on our call, and we understand there will be a number of questions. So we please ask that you use the Q&A or the chat function on your computers to set up those questions, and we ask that you keep them on the topics addressed today. If we do not get to your question or you have one on another topic, always feel free to email Government Affairs with MSV at govtaffairs@msv.org. So with all the logistics and all that fun stuff out of the way, I'd like to welcome Dr. Rossheim and Dr. Briggs-Hagen.
Great, thank you. Good morning, and excited to see so many people joining the webinar this morning. So I'm going to be starting off the presentation, and then we'll hand over to my colleague, Dr. Rossheim, halfway through. If you move to the next slide here. So our objectives of the talk this morning are to give you an overview of the current status of COVID-19 in terms of the epidemiology, both globally and in Virginia. We will also provide an update on the CDC and VDH guidance in regards to testing, some background information on the actual tests and how to interpret them, as well as present the Virginia Department of Health testing algorithm. And we've included in this deck a number of useful resources that we won't be presenting that we think would be useful for you to have on hand. We do want to make sure we save plenty of time, however, for the question and answer section. So we will try to be relatively brief in our presentation so that we can hear from you all what is happening in the field and what your concerns are. Next slide. So I'll start off with an overview of the epidemiology. Next slide. As most people on the call are well aware, COVID-19 was really identified first in Wuhan, China. In December 2019 is when it became publicly known and was been shown to be caused by the virus SARS-CoV-2. Specifically named COVID-19. And global spread has, of course, happened very quickly. A travel-related case was first reported in the US on the 21st of January of this year, WHO declared COVID-19 a global pandemic on March 11th, and it was declared a national emergency here in the US on March 13th. At this stage, the WHO situation report from earlier this week reported over 16 million cases globally and over 650,000 deaths. Next slide. As we start to move a little bit more locally in the US, again, earlier this week, there was a report of over 4,200 cases and 147,000 deaths on the CDC website. This has, as many of you know, exceeded now 150,000 deaths as of this week. And hopefully you're accessing these resources, but it's possible to go onto the CDC webpage and look at cases by state and even within the states by county, and look at the case counts as CDC is collecting them on a daily basis as well. Next slide. The Virginia Department of Health has a very useful dashboard, and we've included throughout these slides the links, again, just to make sure you have an easy resource tool that you can go to keep yourself up to speed on coronavirus as well. And so at the bottom of this slide, you see the link to the Virginia Department of Health dashboard, which shows both the case counts by county, but also shows the rates per 100,000. So you're able to see if the county you're in is especially high for burden, which is shown on this slide, and you can see very high burden in the Northern Virginia and Southeastern Virginia areas. But you can also see how your county compares to the rest of the state in terms of per population rates of COVID-19. And the slide, the dashboard includes cases, hospitalizations, and deaths. As of earlier this week, there are nearly 87,000 cases, over 7,000 hospitalizations, and over 2,000 deaths reported here in Virginia. Next slide. When we look at testing on a national level, there have been nearly 43 million tests reported, about 10% of which were positive. And this graph on the right shows new cases by day in the US, with that initial peak earlier on that started to decline. And then we saw, of course, that substantial increase again as lockdown restrictions were eased, and continue to see increases in many states. Next slide. It's a very similar pattern that we look at in Virginia. The good thing to note is the positivity rate is a little bit lower than it is nationally at 7.5% earlier this week, and I believe it's now down to 7.2% today. But you see a similar trend with a substantial increase early on, declines during the periods of more intense restrictions, and some increases as the summer has evolved over the last month and a half. Next slide. So I'm going to present the CDC testing guidance, and then my colleague will present the Virginia Department of Health testing guidance. These are largely aligned, but we wanted to just again make sure that you have these resources and that we were clear on what's in both for those of you on this call. Next slide. So the CDC testing guidance provides description of 5 populations for which SARS-CoV testing with viral tests, so this is the nucleic acid or antigen test, is appropriate. These include individuals with signs or symptoms consistent with COVID-19, and this image here on the right shows the typical signs and symptoms that we tend to see in patients. It includes guidance on asymptomatic individuals with recent known or suspected exposure. And this largely, the contact tracing guidance for CDC really centers around people who've had over 15 minutes within a 6 feet distance, as well as risk through direct exposure to secretions. Asymptomatic individuals known or suspected exposure for early identification in special settings. This is largely around nursing homes or settings where there's increased risk due to a vulnerable population. And then individuals being tested to determine resolution of infection. That population, there's actually been a recent update to that I will go into further detail on the next slide. And lastly, individuals being tested for purposes of public health surveillance. Next slide. So what has changed most recently in CDC guidance? So late, now just about 2 weeks ago, CDC issued an update that a test-based strategy was no longer recommended for determining how long patients should be on isolation or transmission-based precautions, except for in rare circumstances. So what does this mean? Previously, CDC had guidance on both test-based and symptom-based strategies for determining when to remove isolation. At this stage, the test-based strategy should really only be considered for people who are severely immunocompromised and in consultation with an infectious disease expert. For pretty much the rest of your patients, you will be using a symptom-based strategy for determining when to discontinue transmission-based precautions or when to discontinue isolation. And that would be 10 days since their symptoms first appeared, or if they are asymptomatic, 10 days since their positive test, and at least 24 hours since their last fever. This is also a change in that it was previously 72 hours. They also changed the last bullet there in terms of instead of just respiratory symptoms have improved, general symptoms have improved. So this could include GI symptoms if they presented with those as well. And this was meant to be more inclusive of the typical presentations. Patients with severe to critical illness or who are severely immunocompromised are recommended to have at least 20 days of isolation or transmission-based precautions, and the rest of the criteria are the same, at least 24 hours since the last fever and improvement of symptoms. There was a lot of, I think, discussion around these guidelines and why they changed, and so we've included in the resources a specific slide that has the list of the evidence that underlied CDC's decision. A lot of it had to do with looking at people who were persistently positive, and there was findings that people could be persistently positive up to 3 months following an infection, and wanting to avoid prolonged isolation in people who are persistently positive but no longer infectious. And it looks like from a number of studies that those people, by and large, have not been shown to cause secondary infections. So please do use that resource, and hopefully we'll have further discussion in the Q&A section about this if there are questions as well. Next slide. So the last slide that I will present is just on the specifics of testing for healthcare personnel. I think this would be of interest to many of you as well. So the 4 categories of testing that are recommended for healthcare personnel are those with signs or symptoms, that's the same as the general population, asymptomatic healthcare personnel with known or suspected exposure, and there's a little bit more detail around who's considered exposed for healthcare personnel as compared to the general public. Testing asymptomatics with known or suspected exposure or for early identification in special settings such as nursing homes, and then testing those who've been diagnosed for determining when they can return to work, when they're no longer infectious and can return to work. Under that last category, the same updates apply as what I just mentioned for the general population, that more often than not, a symptom-based strategy is going to be recommended. And in terms of who is considered an exposure for healthcare personnel, there's a specific CDC page that I've listed at the bottom of this slide entitled Risk Assessment that provides detail on when somebody is considered high risk, because of course we know many of you are seeing COVID-19 patients or suspects on a more frequent basis. So those who are considered high risk are those who've had prolonged contact with a patient visitor or another healthcare worker with COVID-19 at the time, not wearing a respirator or face mask, not wearing eye protection if the person who you were engaged with was not wearing a face covering, or not wearing all recommended PPE for the particular activity. For instance, if this is an aerosol generating procedure, full gown, gloves, eye protection, and respirator. And so that caveat is just that for those of you who are healthcare workers, there's this expanded definition of what a close contact is. With that, I'm going to hand over to my colleague, Dr. Rossheim, to talk about the Virginia testing guidance, as well as to give some more specifics on the types of tests. Thank you.
Hello, my name is Dr. Brooke Rossheim, and I want to say good morning and welcome to, I'm glad that everybody's participating in the webinar. Can I get the next slide, please? So as far as VDH's testing guidance, the main thing is we want to test all patients who have symptoms consistent with COVID-19. And as you've heard before, symptoms, fever, chills, cough, dyspnea, fatigue, myalgias, and the other symptoms or signs listed on the page. I will say that COVID-19 can present in a large variety of ways, and so you really have to be on the lookout for that. The older adults may not present with typical symptoms. They may present with delirium, confusion, or falls. And children can present with similar symptoms as adults, but they may be milder. And then another thing in children is children may develop what is known as the multi-system inflammatory syndrome, which can occur during or after COVID-19 infection. Next slide, please. As far as testing guidance goes, practitioners can consider testing the following people for medical reasons, and this is if they have sufficient supplies to do so. That would include pregnant women in labor, neonates born to women with confirmed or suspected COVID-19, people having aerosol generating procedures, so an example would be bronchoscopy, and others. People who are undergoing time-sensitive surgery would be another reason, and immunocompromised people who are admitted to the hospital. Another consideration regarding testing is for containment purposes. And again, that's if sufficient supplies are available. So that would include close contacts of case patients. And you can see in the box on the right-hand side the definition of a close contact. People who work or live in a long-term care facility, and then people who work or live in a congregate setting other than a long-term care facility. So, for example, a jail or a group home that is having an outbreak. So these are considerations for testing, because one of the things we know now is that testing is becoming somewhat of a scarce resource. Next slide, please. So this is VDH's guidance, current guidance on prioritization of COVID-19 testing. And you can see that we have two rows, high priority for testing and priority for testing. And then we have two columns, testing done through a private or commercial lab, and then testing through the state public health lab. So if we look at the high priority group and as far as the upper left-hand box, so people that we would be very interested in testing would be those hospitalized patients, healthcare workers and first responders who have COVID-19 symptoms, uninsured or underinsured patients who have COVID symptoms, residents and workers with COVID symptoms in or newly arriving to congregate settings. So that could be long-term care, a prison, a jail, or another kind of congregate setting. As far as the public health side for high priority, that would be contact and outbreak investigations. And then you see, again, residents and workers with COVID symptoms in or newly arriving to congregate settings, and uninsured or underinsured persons. For those two groups, the ones that overlap, if those individuals can be tested through a private or commercial lab, that is great. If they cannot be, then a consideration is to have them tested through the state lab. And then you can see the priority groups below. Can I have the next slide? So this is a slide that you've seen before, which talks about the trend in terms of testing in Virginia. You can see the bars, the blue bars indicating that testing has gone up nicely in terms of the number of tests done per day. As Dr. Briggs-Hagen talked about, you can see the percent positivity rate. That's a 7-day moving average, which is now at 7.2%. And can I have the next slide, please? So I want to talk for a few minutes about COVID-19 tests that are available and interpretation of those tests. Next slide. So depending upon the study, about 25 to 40% of COVID-19 patients are asymptomatic. Now, one thing, not only with COVID, but with any illness, is that we always have to, correlate the lab result with the patient. And so if it looks like the clinical picture is not consistent with the lab result, then we have to start asking about why. And is COVID the right diagnosis? Is there another diagnosis? And then another thing that the CDC came out with recently is for people diagnosed with symptomatic COVID-19, retesting them is not recommended for asymptomatic patients within 3 months after the date of the symptom onset. And that's except in special circumstances with the input of an infectious disease specialist. So hopefully this will help with testing because it will cut down on the amount of testing that is done for those people who have been diagnosed and recovered. And so this is helpful. So next slide, please. So first test I want to talk about is the molecular test, which is PCR. This is reverse transcription polymerase chain reaction testing. This is the preferred VDH test for diagnosing acute COVID-19. It detects the presence of SARS-CoV-2 RNA. As many of you know, this is typically done on an NP swab, but it can be done on other specimens, other upper and lower respiratory tract specimens. You want to make sure that you're using a PCR-based test that has received an emergency use authorization or an EUA from the FDA. And you can see the link there, which will take you to the FDA webpage, where you can see all of the different kinds of tests, not just PCR tests, but all the different tests that are available and that have an EUA from FDA. As of July 26th, there are 4 point-of-care rapid tests, rapid PCRs, that have an FDA EUA. PCR tests generally have a high sensitivity, which means that a negative test is almost always going to be a true negative. So there are very few false negative tests. Obviously, PCR test performance, and just like any other test, depends on the adequacy of the test specimen. If you're doing an NP swab, you want to make sure that you get nasal or nasopharyngeal secretions on the swab. That is important as far as the testing goes. Next slide. So I've included a couple of videos. One is from the New England Journal about collecting an NP swab. One is done by VCU and VHHA about collecting a deep nasal swab. These are both short videos, definitely worth your time to watch. Next slide. So what do we do with a positive PCR test? So if the patient is positive, they are presumed to be infected with SARS-CoV-2 and to be contagious. We're going to isolate that patient and until he or she meets the criteria to discontinue isolation, and you heard about that earlier in the presentation. If someone has a negative PCR test, that's indicative of no active infection, and what we're going to do is we're going to advise them about standard infection control measures that are listed there. Now, if that patient is a known close contact of a COVID-19 case, We want them to continue to self-quarantine for a total of 14 days following their last exposure to the positive case. And if a patient has clinical symptoms consistent with COVID-19, but yet they have this negative PCR test, we want to isolate them, contact the local health department, and consider repeat testing despite that negative test. Next slide. So viral antigen testing is out there, and this detects the presence of the SARS-CoV-2 protein antigens, the nucleocapsid antigens. As of July 26th, there are only 2 viral antigen tests that have an FDA EUA. Both of these tests can be done either at a commercial lab, and both are available as a CLIA-waived point-of-care assay. Viral antigen is typically detected in the acute phase of infection. The issue with the viral antigen tests is that they are less sensitive than PCR, and this can generate false negative results. Next slide, please. Can you go back one? Okay, so if we have a positive antigen test, what that means is the nucleocapsid antigen is present, and according to the FDA in the EUA, we need to clinically correlate that with the patient history and other diagnostic information needed to determine infection status. So we can't immediately jump to they are positive. So we've got to look at some clinical information. If the antigen test is negative, obviously the antigen is not detected. And what FDA has in their information is that that result should be treated as presumptive and confirmed with a PCR test. And also, again, we need to take into account the patient's clinical presentation. Next slide, please. This is an algorithm from VDH as of July 9 that goes through testing criteria. I'm not going to go through this, but I would encourage you to take a look at the nice algorithm and provide good rationale for why we would do certain tests and sort of how to proceed. Next. So this is an overview of the lab testing capacity as of July 22nd. You can see that, if you look at the left-hand portion of the slide, you see that most testing, about 70%, is done by commercial labs, about 24% by hospital labs, and about 6.5% by public health labs. And then if you look at the graph on the lower right, you see that the commercial labs, in the blue line, we had a peak, and now that is down to about 4.8 days in turnaround time. The hospital labs have done very well. That's the orange line, which shows that they are down to about 1 day of turnaround time. And then the public health labs have sort of crept up a little bit and are now at about 3.3, roughly 3 days in turnaround time. And then at the upper right is efforts that we are doing to address delays in turnaround times. We are looking at refining our test criteria as far as priorities of who should be tested. We are looking to bring on new labs to expand our capacity. And we're looking at the emerging testing modalities, and one that you've probably read about is test pooling. At this point, a couple of labs do have an FDA EUA for pooling tests, and that's one way to cut down on the number of tests that need to be done on each individual. Next. And these are key resources that I definitely would encourage you to look at. The top three are more general COVID resources. The bottom four are more testing related. And then in the slide deck after this, you will see that we've included about 10 additional slides that provide more information. Next slide. So I want to thank you for your attention, and at this point, we would like to take your questions and also open the floor to discussion.
Thank you very much for your presentations. This is Richard Such. I am the immediate former president of the Medical Society, and I had some connection problems at the beginning, so Tim Farber filled in very ably to start this webinar. Thank you, Tim. And at one point, my video was labeled as Tim Farber, so he'll get all the credit for this. But we do encourage you to submit questions into the question and answer tab at the bottom. And there is one question that has been submitted so far, so let's just start with that one. Quidel has updated performance data for performance of its rapid antigen FIA test at 96.7% versus PCR when used during the first 5 days after symptom onset. They suggest that no PCR test is needed to follow up on a negative result in a symptomatic patient in that window. Does VDH agree?
This is Brooke Rossheim. You know, in the FDA EUA letter, that is what I've seen most recently is FDA says that that a confirmatory PCR is you know, is the way to go. So that's what we would take our cue from. So at this point, unless FDA has updated its EUA, I think we would stick with the same answer.
Okay, thank you. I have a question. I've been following these metrics fairly closely. And one thing that isn't really obviously on the VDH website is where Virginia stands compared with other states in terms of testing. And I looked that up a couple of days ago, and I believe that Virginia was 37th in the number of tests performed per 100,000 people. Why is it that we seem to be lagging the other states in the amount of testing that's being done? Is there a reason for that, or how we can improve that?
I'd like to see if Dr. Toney, Dr. Denise Toney, who is the director of DCLS, is on the line.
I believe she is. Are you muted, Dr. Toney?
I'll just make a comment. Oh, go ahead, Dr. Toney.
Can you hear me?
Yes.
Yes.
So I do know that early on, Virginia did rank lower in overall testing, but I do believe that with concerted efforts recently, our numbers and our testing percentage has dramatically increased such that we are testing on average over 10,000 tests a day, which is in line with what projections are for what should be in the range of appropriate testing for our population base.
Okay, I thought the data that I was looking at was current, but maybe it was a little while ago, and I know that testing continues to increase. Another question that I have, and then I'll go to some more questions that have been submitted. We seem to be still reserving tests primarily for patients who are symptomatic or who have direct contact, which increases the pretest probability of a positive test, and yet we're looking for decreasing the number of percent positive tests. That has always seemed to be a bit of a contradiction to me. Is testing available for the general population in Virginia?
Yes, testing is available through multiple platforms. We now have literally hundreds of testing sites in Virginia. That would include people's doctor's offices, urgent cares. We have pharmacies that are doing testing. We have federally qualified healthcare centers, free clinics, and the list goes on from there. So there are many sites that are doing testing. We're trying to focus our, given the fact that testing is a limited resource, we are trying to focus our effort on those who are symptomatic. If we had testing as an unlimited resource, then we would be looking at the more asymptomatic. But the current position that we're in is, testing is not an unlimited resource at this point.
Another question that's come in here, and go ahead.
Sorry, yeah, I just wanted to add a comment to the two last questions to you. One, I would just say one positive thing that you see with Virginia when you compare across states is this lower positivity rate in terms of who's being tested. So I think, it does speak to the scale of testing, that it's 7.2% and higher than the national average of 10%. And in terms of, looking at that rate coming down, that really is a metric for, are your mitigation measures working? Are people wearing masks? Are people physically distancing? So we want tests to be prioritized, but we want to see that measure come down more as a means of assessing the mitigation measures and if they're working or not. If that makes sense. Thanks.
Yeah. Another question. Go ahead.
Oh, sorry. Another thing I'd like to mention, and this is Brooke Rossheim again, is that on the VDH website is a testing locator. So we've got a mapping locator where people can type in where they are, and then it will show them where is the closest place that you can get tested for COVID.
Another question that's come in, and I think I know the answer to this, but I'll let you all answer it. Is the percent positive rate broken down by district?
Yes, it is.
Can you explain how to do that? You have to go to the top under testing and scroll over and hit the tab and then select your district. Is that correct on the website?
That's correct. Yes. Yeah, it is available on the the same the same page where the other graphs are located. Yeah.
Right. Another question that has come in here for rapid RT-PCR pre-op testing, what is the false negative rate? I guess the concern there is that if you're testing people before surgery and you have a false negative, you might unknowingly have healthcare workers being exposed.
Well, one of the benefits of PCR testing is that the false negative rate is typically very low. So maybe on the order of 1% or so. So basically, if you've got a negative, that the likelihood is very high that is a true negative.
Yeah, I think the question was about the rapid tests.
Oh, okay. I don't know right off the top of my head the data, in terms of the rapid test. Melissa, is that something you're aware of?
No, I mean, the one thing I was going to add, I mean, so if it's PCR, it's, you know, as you mentioned, if you're looking at antigen testing, then you would consider that it needs to be retested. I mean, the one thing I would add though is if you are testing too far in advance, it really is just a snapshot in time. And so, you know, if you're testing 3 days before the surgery, then it's hard to say that, you know, there hasn't been evolution over time. So that's the one thing I would raise in terms of, you know, how sure are you as to that test. It somewhat depends on exposures and whether or not how close the testing and result are to when the actual procedure is.
What I would need to do for the rapid PCR test is look that information up in the information about the test to see what they state as the false negative rate.
I seem to remember early on some reports that there was a high false negative rate with some of the rapid tests, but I don't know what the state of that is right now. So someone asks here a question I think you already answered, but I'll repeat it for them. Does a negative antigen test need to be followed by a PCR test?
Yes, it does. That's one of the downsides of an antigen test. As noted in the slide, that in the FDA EUA information, it does talk about the fact that FDA recommends that a PCR test be done to confirm that negative.
Okay, someone asked if the webinar will be available later, and I think the government affairs answered yes, it will be recorded and posted on the website. Someone else says that there's still a shortage of swabs and test kits in their area. What are resources that they can turn to address that?
Hi, this is Dr. Toney. I can answer that. While we have heard that there are folks that are experiencing difficulties in finding swabs and the viral transport media, we have been working with VDEM as well as DGS to identify vendors that are able to supply these products. In addition, the federal government has extended their allocation of swabs and transport media to the Commonwealth, and DCLS is receiving these items, and we are quickly allocating them out to hospitals, federally qualified health centers, free clinics, and the local health departments, so that they have the materials they need to collect specimens for public health and priority clinical testing.
Okay, here's an interesting question, because as universities have students coming back to campus, someone says UVA is requiring students to be tested prior to moving into the dorm. Does this make sense for students who tested positive during the summer but have fully recovered? I guess they're requiring all students to be tested.
I will tell you that that's been a subject of a lot of discussion in the Testing Advisory Council. You know, the general feeling is that you know, there is some you know, I mean, basically we you know, VDH and CDC do not recommend this kind of testing. You know, this is because we're in a time of testing as a limited resource. You know, this is thousands and thousands and thousands of tests, and so at this point, we don't recommend that for you know, asymptomatic students.
And just to mention on top of that, Dr. Rossheim, you know, specifically in the question about those who've tested positive before, as was mentioned earlier, we've seen that they can continue to test positive for an extended period and not be infectious. So, so that would be problematic for the university if somebody has already gone through coronavirus and then they're wanting to, restrict them from attending classes or so on because they continue to have a positive PCR even if they're not infectious. So that would be a concern as well.
Yeah. Someone else has chimed in here to sort of echo what you've just said. VDH and CDC do not recommend universal testing for students. Further discussions are being held with the universities to see how those plans may be altered in the future based on new information, but we are not asking the universities to change their published plans at this point. So it sounds like that is a subject of discussion.
Yeah.
Someone asked here about, let's see, where was that question? Oh, sorry. Oh, someone said, you have touched on simple tests that can be done daily, like a pregnancy test. Any idea of a time frame for this? I don't remember anyone mentioning that, but I know it's been talked about, self-testing.
I've heard about, I've read about this as well. Denise, do you want to add anything?
I have not heard of any at-home self-administered tests that are going to be coming onto the market anytime soon.
What about? Go ahead.
I was going to say most of the rapid point of care tests are required to be performed either in a location that has a waived status to be able to do testing, or either in a moderate to high complexity testing laboratory.
What about simple tests that a physician could do in their office? Maybe that's what this person is getting at, like a pregnancy test. This person says, I'd like to test daily on higher risk individuals who may pass the virus on but need an immediate result.
Well, the current testing that's out there is you've got 4 PCR point of care tests that are CLIA waived, and you've got 2 antiviral antigen tests that are CLIA waived. There are saliva tests that are out there also. So, that's what we have at this point. I mean, the point of care machines generally give an answer within 30 minutes. So you're going to get a result. Now, one thing to, as far as the viral antigen test to keep in mind is that, if that result is positive, you've got to take that, the patient's clinical picture into account. The FDA talks about that before you call them positive. And then if you've got a viral antigen test that is negative, the recommendation is to follow that up with a PCR test. So that's one thing just to keep in mind. The 4 PCR tests are out there, and again, they are also provide results within, it depends on whether you're negative or positive, and again, within about 30 minutes.
Okay. In terms of testing locations, someone reminds everyone that there is a testing location map, and I think you said that on the VDH website, if people are wondering where they can get testing.
Yes, the map is on the VDH website. They put in their address, and it will tell them where the nearest testing location is. Now, it may not, it may not tell them whether they have rapid test capability or just regular, sending to commercial lab. And and another thing that's helpful to do is for people to call ahead because some places may be scheduling by appointment. They may not be doing walk-ins. So just to find out a little bit more information.
Okay, there's a very broad general question here, which may be maybe a good last one to try to tackle. Someone asks, what is the plan moving forward? More testing. What is the overall goal and what is the end point?
Well, I think this is actually a really good question because the plan going forward is, right now we're in a situation where the demand for testing is currently outpacing the supply of it. And the goal is that we want to have testing, really as not a scarce resource. We want to get to that point where people who, that we don't have to talk about reprioritizing groups of whom to test. So definitely we do need more testing available. We need to have faster turnaround times because that is important for clinicians who are seeing patients, because having that information in a short period of time allows for better decisions to be made than if the results come in 4 days later. That's also important from a public health perspective because it allows us to act quicker as well. So the overall goal is, as you saw, one of the slides I talked about is, we are looking at bringing more lab capability online. We're also looking at pooling of testing. Pooling is a way where you can test multiple people simultaneously, and then if the pool comes up positive, then you go back and you test each individual person in the pool. So this is a strategy that allows you to really maximize what now is a limited resource.
Okay, do any of the other panelists that are on have anything they'd like to add?
Just looking at the Q&A box, this is Melissa again. I just wanted to note there was a link that was shared for a home test kit. I don't know if Dr. Toney has any experience with this, but this to not be home testing, but a collection kit rather to collect your sample and send it in for analysis. So this is a little different than what we were speaking about earlier, which is home testing not being available. I would raise concern about whether or not a person self-testing is going to actually get an adequate sample. I think any of you who've done testing know it is quite somewhat invasive. So I don't know if you've done this before, Dr. Toney, but I did want to raise that difference on there.
I'll just make a quick comment. I saw the question too. I think they were referring to the Pixel kit, which is an at-home kit that is offered by LabCorp. It was my understanding early on, and I have to confess that I haven't checked back in, that when LabCorp was deploying these test kits, they were very limited to only certain states and only certain individuals that fit into a high-risk category. But I don't know if they have expanded this test kit offering more widely to the general public. But you are correct. It was a kit that they would send you the kit, you collected a nasal sample, you shipped it back to LabCorp, and they did the testing. You didn't do the testing at home yourself like a pregnancy test.
And just in terms of the messaging around flu, I do see this flu vaccine question. I think one thing that we can definitely tell our patients is getting the flu shot will, decrease their likelihood of getting the flu, and that decreases their likelihood of getting ill and needing to present to a healthcare facility. So I think in terms of, just protecting themselves from coronavirus by decreasing their potentially needing to go to a healthcare facility, it is something that we should be encouraging patients, especially patients that would be high risk if they did get sick and did need to seek care.
Right. Okay, well, I think we have come to the end of our time. Someone did ask how one obtains CME for this. Can Tim or someone from the staff address that?
Hi, yes, this is Taylor Woody from MSB. We will take care of submitting the names of everyone who is on the webinar this morning to VCU to get credit. And then if afterwards you have coworkers or colleagues who are interested in getting CME for this, it will be posted on the VCU website for them to watch and get credit as well.
On the VCU website?
Yes, and that is linked on our MSV website where they can go that information.
Okay. All right. Well, thank you very much for all of you who tuned in this morning, and thanks particularly to our panelists, Dr. Brooke Rossheim, Dr. Melissa Briggs-Hagen, Dr. Denise Toney, and Dr. Diane Woolard. We appreciate very much your taking time to update us on this and continue to keep the physician population informed about the latest information on COVID. So thank you very much.
Thank you.
Thank you.